A very good afternoon, and I would like to uh, welcome everyone to this session on Corneal Diagnostics. And this is the real world applications of Corneal Diagnostics, a case based approach. But before we start our instruction course, we have a very, very interesting talk by Dr. Shizuka Ko. She's from Japan, and her topic of her talk is corneal power analysis with OCT in keratoconus from mild to advanced. And this is such a challenging thing because when it comes to planning cataract surgery in these patients or phakic IOLs or some intervention in these patients, we do require some knowledge how to reach the corneal power and how to do the analysis. Usually we rely on the pentacam or we use the eye trace. So let's hear what she has to say on corneal power analysis in keratoconus. Dr. Ko, please.
Sorry. What happened? Coming?
Please put Dr. Ko's talk. Dr. Ko's talk. She's the keynote address. She has the keynote address in this session. Yes, thank you.
Good afternoon, everybody. It is my great pleasure to give a talk today. I'd like to thank the committee member of AIOC for kind invitation. My name is Shizuka Ko from Osaka University, Japan. So keratoconus is a progressive corneal ectatic disease, typically onset in second decades of life. It is characterized by steepening, distortion, and epicrysini of the cornea, leading to visual deterioration due to the irregular astigmatism. These are the typical clinical keratoconus signs. If you see these signs as the slit lamp, the keratoconus diagnosis is very easy. But however, there are many cases without clinical keratoconus signs. In such cases, we have to rely on corneal imaging. Right now, there are variability in diagnosis and terminology for keratoconus, especially for if some eyes don't have any clinical keratoconic signs, but have some kind of signs in corneal imaging, subclinical keratoconus or keratoconus suspect or frumiferous keratoconus can be used. But there is no definite consensus for the definition. Let me revisit the corneal topography and tomography. It is very important to recognize that corneal topography can be characterized for anterior corneal surface only. However, corneal tomography can characterize both anterior and posterior corneal surfaces. Currently, even when the tomography-based imaging techniques are used to obtain the corneal shape images, sometimes some people say corneal topography was used, but in this way, recently corneal topography is used, such as corneal shape imaging. I'd like to mention this just in case. Swift source OCT have been introduced recently. I believe many people are using already, and this has a higher speed and higher sensitivity. Especially anterior segment OCT is powerful even when the keratoconus has severe scarring or haze, or if the keratoconus is advanced, it can actually image both anterior and posterior surfaces clearly. This shown here is the case keratoconic eye after acute corneal hydrops. If usually corneal haze or corneal scarring makes the imaging very, very difficult, and usually we cannot actually get the good image from that eye. But the OCT uses the 1310 nanometer wavelength, so it can penetrate opaque tissues and provide clear images. This is the advantage of use of OCT. As you know, foraminifers keratoconus is a fellow eye of very asymmetric keratoconus, which does not present with clinical or topographical signs, while one eye manifests with clinical keratoconus. Sometimes this is actually called as feral eyes of very asymmetric ectasia. Right now, there is a variability in diagnosis and classification of keratoconus. As I said, there is a kind of a mixture of subclinical keratoconus or keratoconus suspect. So to avoid such kind of confusion, I'd like to propose a very simpler classification based on clinical sign as the slit lamp and topographical sign based on the Placido topography. So clinical keratoconus, topographic keratoconus, and pre-topographic keratoconus, and normal eye. Sometimes this is, as I mentioned, this is called as very asymmetric ectasia with normal topography. But right now, I'd like to go with pre-topographic keratoconus. This is a classification based on slit lamp and topographic sign. You don't need any special devices. You can just classify based on your slit lamp and Placido topography. As I mentioned, normal has everything is okay. Pre-topographic keratoconus has no sign at the slit lamp and Placido topography, but this is the fellow eye of clinical keratoconus. Topographic keratoconus has an abnormal sign as the Placido topography. For the clinical keratoconus, we classified into three groups. One without no scarring, and number two is keratoconus with scarring in the anterior stroma. And number three is a clinical keratoconus with scarring in the posterior stroma with history of acute hydrops. This is a kind of severe type. I'd like to mention about the Fourier analysis with OCT. Fourier analysis is a kind of useful tool with anterior segment OCT. So the corneal dioptric data can be divided into four components: spherical, regular astigmatism, asymmetry, and higher order irregularity for both anterior and posterior corneal surfaces. So actually, asymmetry components and higher order irregularity are the components of irregular astigmatism. This is an example of keratoconus. Let me, please forgive me, this is a kind of very busy slide. Actually, it looks like mandala. So I actually show the representative Fourier map cases from the representative case from all six groups. So you can see the anterior Fourier maps and posterior Fourier map. as I mentioned, purple is the normal, and the red is the color, the severe the keratoconus. So if you look from the up and low level, you can see the kind of significant actually color changes with the severity of keratoconus. This is a scatter plot. So for the to see the relationship between the corneal thickness and Fourier indices. So the upper level is the anterior Fourier indices from the anterior corneal surface, and the low level is the Fourier indices from the posterior surface. You can see the kind of very good, nice relationship between the corneal thickness and the Fourier indices. Again, the redder the color, the keratoconus is severe. You know, superior inferior power asymmetry is a characteristic of keratoconus. So, visual impairment due to the irregular corneal astigmatism is actually by the increase in coma, kind of superior inferior asymmetry. So we focus on the corneal asymmetry component from both anterior and posterior components. When we look at the relationship between the corneal thickness and the asymmetry components, you can see the nice relationship between these parameters. When we look at the discriminating ability of the Fourier indices between normal eyes and pretopographic keratoconus, actually FFKC, posterior, the Fourier indices from the posterior cornea asymmetry component shows the best ability. In summary, Fourier analysis using anterior segment OCT can evaluate anterior and posterior corneal irregular astigmatism of various keratoconus stages, from very mild to advanced, including severe cases with corneal scarring. Thus, distribution data enabled us to visualize the increase in all Fourier indices in either the anterior or the posterior cornea as the keratoconus severity increased. Thank you for your attention.
Thank you, Dr. Ko. That was a very interesting talk. And now you're using the Cassia 2 topography in all cases. Are you using that, or are you using that in all cases? The Cassia 2 topography.
So actually, we are using Cassia 2 topography by Tome. Yes, Cassia 2.
By Cassia 2.
Cassia 2, yes.
Only.
No. Of course, we actually measure all the patients with other devices. But in this study, we just actually focus on the OCT, anterior segment OCT, just Cassia 2. Of course, and in the next study, we'd like to actually thinking about the investigate to relationship with from the parameters from other devices as well. But the important thing is actually, as I mentioned today, OCT can actually analyze the topographic data even in the advanced cases, because other blue light like from the rotating shine-proof camera cannot actually visualize the corneal parameters in the advanced cases or hazy cornea.
In case there's a disagreement between pentacam K1, K2 values and the Cassia 2, K1, K2, which would you choose between the two? If there's a disagreement in the K1, K2 values and the axis, for example, do you have a patient for toric IOL or something like that? Which would you choose?
So you mean the Cassia 1 or Cassia 2?
If pentacam and Cassia 2 do not agree with each other, the reading, what would you choose between the two?
Oh, so you mean that if the Cassia 2 cannot dictate the imaging. I think this is a very, very advanced cases. So most cases, we can actually get the data. Of course, these data, we already actually check the quality of the data, all okay, yes.
Any questions from the panelists, Professor Jain, Dr. Basak, Dr. Chintan? Any questions? Well, thank you so much. We really enjoyed that. Thank you. उसको
How are you? Nice talk.
Well, we'll proceed with the instruction codes. So I have with me a very, very experienced faculty, and myself, I'm Dr. Amit Gupta. I'm from the Advanced Eye Center, PGI Chandigarh, and Professor Arun Jain, who will be speaking on Pentacam and elevation-based tomography. He's also from the Advanced Eye Center, PGI Chandigarh. And then we have Professor Chintan, and she is also working as a professor in the Advanced Eye Center, PGI Chandigarh, with me. And we also have Dr. Samar Basak, and we all know him for his skills in lamellar corneal surgery, DSEC and DMAC. But many may not be aware that he was one of the earliest people in India to start with the LipiFlow and LipiView, and he has a very vast experience. And we are all waiting to hear his talk. And Dr. Rishi Mohan, for some reason, could not make it. So we will not be talking about corneal biomechanics in this particular instruction course. And without any further ado, I would like to invite the first speaker, and that is this slight change in order since Dr. Chintan has to go for judging of the free papers. I would like to invite Professor Chintan Malhotra for her talk on SIP source ASOCT applications for the anterior surgeon. This will be followed by Professor Arun Jain on elevation-based tomography with the Pentacam AXL, expanding indications. I'll be talking about ray tracing aberrometry for corneal and lens-based refractive surgeries. And Dr. Samar Basak will be talking about tear film diagnostics, which is LipiView and LipiFlow. Over to you, Chintan.
Yeah, thank you, and thank you for making me a part of this course. I'll be talking about swept source ASOCT applications for the anterior segment surgeon. In the previous years that we've had this talk, I've been speaking about the corneal disorders first and then the lenticular disorders. I'll switch that order in this course, and the reason will become evident. So the ASOCT systems, we have three, and as ASOCT has evolved over time, and we have the time domain, which had a very long wavelength, but it had a much lower axial resolution. The depth of penetration was much more, so it could penetrate through corneal opacities. Then we had the spectral domain OCT, like the Spectralis by Heidelberg, which has a lesser wavelength. So it has a lesser scan depth and width, but the axial resolution is extremely good. So it's the best for corneal pathologies. And then we have the swept source OCT, the latest in the OCTs, which combines a swept source along with the long wavelength. So it combines the advantages of both two. And these include the Cassia 2, which Dr. Ko so elegantly spoke about just now, and the Anterion, and there are others. Now, since it combines the advantages of both, it has a greater scan depth and width. It has a good axial resolution, though less than the spectral domain. And another advantage is that it can scan at very high speeds. So it's very good in uncooperative patients or in children. So this is just an example. The picture on this left shows a spectral domain OCT, which has a scan depth of 2 millimeters and a width of 6 millimeters. On the other hand, on the right side is a Cassia 2, no financial interest of course, which has a scan depth of 7 millimeters and a width of 16 millimeters. So we can see that in the spectral domain OCT, If we want to image the lens or the structures closer to the angle, we have to sacrifice the cornea because the scan depth is less. If we view the cornea, then we do not see the lens. On the other hand, in a swept source OCT with a single scan, we can see the cornea, the iris, the angle, and the lens, of course. I'll be limiting my talk to how the swept source OCT is useful for the corneal and the refractive surgeon. Of course, it's very useful for the glaucoma people as well, and they perhaps may be using it, in fact, more than the us, as well as the squint surgeons, because they can visualize the muscles. So the entire lens, including the posterior capsule, can be visualized with the swept source OCT, and which is why swept source OCT has dramatically changed the management of lenticular disorders. So any OCT can give us the corneal disorders, but the lenticular disorders are shown by the this swept source OCT. So I'll be taking you through some different scenarios, which is just basically a photographic documentation of the pictures that we see. So white cataracts, we know that white cataracts of different types, we classify them based on the presence or absence of fluid, the size of the nucleus, and the status of the posterior capsule. Now, this was a MIOCT guided classification given by Professor Tityal's group, where they showed which capsules had which white cataracts had the higher risk of capsule, the extension of the capsular axis. But not everybody may have an MIOCT. So I will just simplify it, how we can evaluate it in the preoperative setting. So if we have this kind of a white cataract where there is no fluid, the nucleus is compact, and we can see the posterior capsule is intact and no posterior polar component, a single stage needle cystotome or a forceps capsulorhexis can be performed safely. On the other hand, if we have an intumescent cataract with fluid pockets present anteriorly, if we do a needle aspiration prior to initiating capsulorhexis and then do a capsulorhexis, that will decrease the sign of a runaway capsule. And then we have certain cases. This is a patient with Fuchs heterochromic uveitis. This was a young lady, and this cataract is almost like a football. Most of the fibers are superiorly the swollen lenticular fibers, and there's the fluid pockets, if any, are below. So in these cases, there's a very high risk of an Argentinian flag sign, and either a forceps-assisted two-stage CCC is required, which still would carry some risk, or a femtocapsulorhexis may increase the safety. So that's one situation. Coming to posterior polar cataracts, we know that they are fraught with risks in the surgery. So different authors have given different gradings of the posterior polar cataract. This is just one that I've shown. Each grading is based on the extent of how much the posterior capsule is visualized with the posterior SSOCT. And as the extent of involvement increases, or if you are not able to identify the posterior capsule, the risk of an intraoperative PCR increases. This is one of our cases. This is a grade 2 PPC. We can see that the whole of the posterior capsule is involved, but we can visualize it. We were able to do surgery safely in this, but we can see that the posterior capsule is lax. There may be a little visco, but it's thin and it's hyperreflective. And the important thing is that SSOCT, its ability to detect PC rupture, it has been shown to have a great sensitivity and a negative predictive value. So it shows 100% sensitivity. That means if you see preoperatively that a PCR is there, that means you will find it on table. If it says that there's no PC defect, you will not find it on table unless it's created intraoperatively. That's a different thing. Around 5% of the cases may be misdiagnosed to have a PC defect, or you may not visualize it when actually there's no PC defect, but the sensitivity is nearly 100%. Then coming to traumatic cataracts. So this is a 10-year-old child, history of trauma with a wooden stick. Of course, our clinical acumen also sometimes tells us that we may expect a PC rupture, but it's so much easier when you can see it, you can counsel the patients, and you can plan your lens and your surgery accordingly. Another case of an iatrogenic traumatic cataract. This was a patient who had undergone intravitreal steroids, developed a white cataract after 6 weeks or so, and one can clearly see the breach in the posterior capsule. So in traumatic cataracts, again, the sensitivity is better than the UBM of SSOCT, and the advantages of SSOCT are that it is non-contact, so it's safer in the fresh wounds, better cooperation in children, but the drawback is that the structures behind the iris cannot be visualized, which could be seen with the UBM. That's the disadvantage of any OCT technology. Phakic IOL is another situation where it's really helping us. So what we are doing, we are using the image to measure the white to white also, although that's not a part of the OCT technology, it's an image, but this can be used for the white to white measurement. More importantly is that we have these nomograms which are built in the NK formula and the KS formula, which help to guide us as to what the lens sizing should be. And we can correlate it with the size that we are getting with our manual measurements. It also gives us a predicted post-operative vault. And the accuracy of these, though not 100%, has been shown to be fairly accurate. Another important measure which I'll speak about just now is the CLR, which is now we are understanding more and more is the crystalline lens rise. And that is a factor. If the CLR is high, that means that if the value is less negative, then one might get a low postoperative vault. So we can see in this, for example, if we get a high vault in one eye, we can tailor the size of the ICL in the next eye to a lower size maybe, if the vault height is not acceptable. And this was a study which has just been published in 2022, where like I mentioned, that they evaluated what were the risk factors for patients who had very low vaults, less than 100 microns. And they saw that patients who had a greater crystalline lens rise, and the other factor they evaluated was the iris morphology. So patients who had a greater concavity of the iris, they had a higher risk of having excessively low vaults. And so perhaps this is something which we should be looking at in a preoperative workup, this iris concavity, and this may be incorporated in the further nomograms as well. Another situation in the lens contours, this is a patient of anterior lenticonus. Again, I would emphasize no technology can take over our clinical judgment. So we should be seeing this clinically as well, but sometimes if it's missed or one is in a doubt, one can clearly see that there's a change in the contour of the lens. And then, of course, I will not be going into this, but Swepsource-based OCT biometers are there. We know that they are accurate. The IOL Master 700, the Argos, the Anterion. They can image through very dense cataracts as well. The accuracy is great, and we can check the lens tilt as well as the fixation. So that's how the SSOCT helps us in the evaluation of the lenticular disorders. From this, I will move on to the second part of my talk, which is ASOCT for the corneal surgeon, which is, it might be a swept source OCT or it might be a spectral domain OCT. So ASOCT is a great tool for the ocular surface tumors. We can monitor the diagnosis as well as the response to treatment. So this clinically we know is a lesion which is extending over the cornea and the conjunctiva. It's an OSSN clinically. The OCT helps to confirm that if we see a hyperreflective thick epithelium with abrupt transition, it's an OSSN. In this situation where it is more useful is in monitoring the response to treatment. So we gave this patient 3 cycles of mitomycin C. Looks almost clear, but the OCT is still showing some hyperreflectivity. And here, so topical reliferon was given for another 2 months, and then there was complete resolution. Another not uncommon scenario, although we don't see it that frequently. So this is an 18-year-old male who presents with this lesion at the limbus. He has a history of allergic eye disease, and this is a 55-year-old lady who presents with an amelanotic patch. Once we are seeing these, we would think of either, that would be the differential diagnosis which we highest on your list, either a pseudoepitheliomatous hyperplasia, a lymphoproliferative disorder, or an amelanotic melanoma. So I've put lymphoproliferative on the top because those are more common than amelanotic melanoma, especially in our populations. And if we see these OCTs of this patient, this is the young guy chap. So we have, and in the lower bottom image also, we have a homogeneous lesion which is hyporeflective as compared to an OSSN which was hyperreflective. It has smooth borders and the overlying epithelium is thin. So both these images are actually from a swept source OCT, and we know this is giving us a great resolution. So this is the picture which has been classically described for lymphoproliferative disorders. And on histopathology, actually, for the young patient with allergic eye disease, it turned out to be a benign hyperplasia of the lymphoid tissue, whereas for the 55-year-old lady, it was a low-grade follicular lymphoma. So just preoperatively also, one can have a great idea as to what the lesion might possibly be. Of course, the diagnosis gold standard always remains an excisional biopsy and histopathology, but OCT is a great tool. I will skip these slides in the interest of time. For both lymphomas and melanomas, ASOCT images do not always help obtain a definite diagnosis, but can help to guide the differential. Then we can also have ASOCT provides us the third dimension for surgical planning of corneal pathologies. Just a few examples. If you have anterior dystrophy, you can plan what depth to go to. I'll rush through these slides. If we have an advanced keratoconus, it helps us to see whether the Bowman's membrane is involved or not, whether we can go ahead with the DALC or not, and what technique of the DALC we can use. Sorry, yeah. And then ASOCT is another great tool in endothelial keratoplasties, we know that. It can help us to see the detachment of the grafts. These grafts can be monitored whether we want to intervene or not intervene in these. In this case, we didn't do anything and it attached on its own. I'm sorry, yeah. So I'll just finish. And the added advantage of an ASOCT is that in a deep DM detachment, which was not picked up on a spectralis, one could pick it up on a swept source OCT. So I'll just finish here by saying that in conclusion, SSOCT provides a greater depth of penetration and visualization of lenticular pathologies has been revolutionized. And if available, it should become a routine part of the workup for the white and the post-traumatic cataracts as well. So thank you very much for your patient hearing. I apologize for overshooting the time and would just like to invite you all to Keracon in 2023, which is happening in Chandigarh in the month of December. Thank you.
8th, 9th, 10th of December.
Well, any questions, we would be more than happy to take. Any questions for Dr. Chintan? And thank you very much. And we'll proceed on to the next talk. And that is by Professor Arun Jain. He's very, very experienced with the Pentacam and the Pentacam AXL, and he'll be talking about elevation-based tomography with Pentacam AXL expanding indications.
Started with the wrong slide. Your question also तो होगा नहीं.
आपको भी क्वेश्चन आ जाएगा सर.
Yeah. Thank you, Amit, for having me as a part of this symposium on imaging. And I'm going to talk about elevation-based tomography with Pentacam AXL, how to use this in various indications in ophthalmology. I am not covering the AXL wave. It's basically adds on a little bit more aberration, angle alpha, kappa, and centration of the lenses. So basically, as already been highlighted by the previous speaker, that there are various gadgets and instruments for doing corneal tomography, which are slit scan based rotating shine plugs as well as OCT based. And I'll be restricting my talk to Oculus Pentacam, which is based on rotating shine plug scanning slit tomography. And basically it has been in use for screening for refractive surgery to rule out keratoconus or ectasia or progression of keratoconus. And of course it has also been in use for doing cornea and refractive surgery in terms of IC390 and intrastromal corneal rings. Basically any corneal based refractive surgery or rule out keratoconus or post-operative ectasia, all those things come in domain of, we can do a imaging with Pentacam and have a good idea about the situation whether the keratoconus is stationary, progressing or what. And in cataract, of course, one can do a lens-based densitometry, which has, as we all know, compares well with the LOX3 classification as far as density of the hardness of the cataract is concerned. And also, especially in post-surgery IOL calculation power, we have this true net power as well as holiday equivalent K readings on pentagram, which can be used to arrive at a good IOL power in such cases. And also it has a use to choose the aspheric IOLs and also in toric IOLs, because it gives a wavefront based cylinder, which is axis is quite accurate. I won't be discussing the application in glaucoma. So screening for keratoconus or form fluus, already it has been highlighted by the previous speaker. So as we all know that on the anterior elevation map, a value of elevation of more than 12 micron is considered normal, and a value more than 15 micron in the central 5 millimeter of best fit toric ellipsoid mode are typically indicative of keratoconus, and similar number about 5 micron more apply to the posterior elevation map, and these values are significant only if present in central and paracentral area and in localized pattern. Higher plus values may be seen in periphery because of astigmatism, and they do not mean necessarily the abnormality. So this is one such front elevation and back elevation. As you can see, the front elevation is plus 27 micron and back elevation is plus 53 micron. So it's abnormal elevation in an island pattern on both the surfaces, and this is the other the anterior elevation of the same eye, which is much higher. And it could be also in the shape of tongue, which is called peninsula, coming tongue-like projection both on the anterior and posterior surfaces, or it could be a full bridge pattern also, which also has a quite great specificity. 95% of the patient of keratoconus may have a bridge pattern in their topographic map, and this is the other eye of the same patient showing great elevation of the anterior surface, and the corneal thickness is quite low, 493 micron. And this is one represented patient who presented for LASIK with this much of myopia. If we see, the thickness is quite okay, and there's a little bit of asymmetric bow tie. But if we see the posterior elevation map, there is significant elevation on the posterior map. So there is a topographic sign. Clinically, you may miss it. And this is the other eye, as already by other speakers. So other eye has a frank keratoconus. So it's a fellow eye of the fellow eye in a case of keratoconus in the other eye. So in case of doubt, we have to look for various parameters on Bellin-Ambrose's enhanced ectasia display and comprehensive pachymetric evaluation. What it means is, like in this case, there is a slight asymmetric bow tie with thin cornea and little peninsula, and what this program does is a 3.5 millimeter optic zone centered on the thinnest point in the is excluded from the reference shape of the calculation. So what does this do is, it creates a new reference sphere which has a minimal effect on the normal cornea but greatly enhances the ectatic area of an irregular cornea. Like in this case, this is with the best fit sphere, but with a new reference shape, this ectasia is enhanced. So the probability of diagnosis increases. This is bad map of one such patient where there is both anterior and posterior elevation. This is nothing but a difference of this two maps on the this side, and red values are significant of they are significant, and the sensitivity of screening for keratoconus suspect or from first keratoconus increases with this software, and it is easier to screen cases for refractive surgery. And this is on this map, you have to look for this values. Overall value here you can see is around 7.84. It is in red. It's beyond 2 standard deviation. Pachymetric progression index is around 2.1, as well as Artmax is around 160. All these are significant, and once the value become more than 1.6 diopter of standard deviation, they are thrown in yellow. Once they go beyond 2.6, which may not 2 point almost 3 standard deviation include 97.5% of the normal population. So that increases the specificity of this program. So these are the various parameters we should be looking for on this map. This is these are 5 values. This is anterior elevation, the thickness variation, then the pachymetric progression, thinness pachymetric point, and displacement of thinness point, and artmax cutoff micron is 399. This is A is ratio of artmax this thing to the thinness cornea, and this is a combined value of this. This combined value is much more important than the individual values. If this is in red, there's definitely no for the surgery. If it is in yellow, you can wait and watch. And this is another patient with frank keratoconus. You can see all the incisions in red, and this is a frank case of keratoconus. And on holiday report, if you see this is normally we are doing a comparison to a best fit sphere, but here we do a elevation on a best fit toric ellipsoid, because cornea normal shape is best fit toric. It's a toric ellipsoid. So if a hotspot on tangential curvature and relative pachymetry which is less than 3% of the variation and posterior elevation more than 15, coincide, it is a definite diagnostic. So this has already been discussed. Form flux keratoconus, this is another patient, 24 years old. Everything is normal, but except for the K rating, which are very high. Even the corneal thickness is normal. So you have to be careful in such cases. You have to ask for family history or disease of maybe in the sibling there is history of keratoconus, or you may go into for genetic testing of these patients where are various genes described in the keratoconus, because all of us know that age is the single most important risk factor for development of keratoconus. And this map shows pachymetric progression. Normal is around 1.2. Here it's a little, maximum is around 1.5. And here you can see the again, a pachymetric progression is in yellow, it's more than 1.6 standard deviation, and the whole D value is also ambiguous. It's not absolutely normal. So you may observe these patients and follow up it after 6 months. And as we follow up, this is the other eye, which has a higher value than the right eye. And even the pachymetric progression is in the red zone. So all these cases are to be followed up closely without doing a refractive surgery. As far as IOL power calculation is concerned in post-refractive surgery eyes, these are the various online calculators available. But of course, with the Pentacam, it gives us a true net power as well as equivalent K readings, because it takes into account the true anterior and posterior curvature as well as the true refractive index of air, tear film, cornea, and the aqueous humor. And these are the various EKR values, which it has been shown that the values at 1 to 2 millimeter are more important than 3 to 4 millimeter. It has been proven by Savani et al. In their paper that the central 1 to 2 millimeter values are much more accurate as compared to the 3 to 4 millimeter diameter. So this is a representative patient, 39 years. This I operated almost 15 years ago. Patient, she had undergone a radial keratotomy. So he had 8 RK scar, axial length was this much, and on manual K, this was the keratometric reading, and on SRKT, this was the lens power coming. So, but on EKR, at 1 and 2 millimeter, the average K reading was around 35, which is less than this. And in this patient, once you calculate with EKR, you get a power of lens of 18.5, but with this one, you get a 17.5. So we will end up hyperopic by 1 diopter. So you target for little myopia. So we targeted 19. So post-op patient got this much of cylinder on day first. Spherical equivalent was still on the positive side. So as far as higher order aberration are concerned, you can choose based on asphericity, spherical aberration, the IOL, which specific aspheric lens you want to use. So based on how much is the asphericity. Just last slide. If the patient has undergone hyperopic LASIK, you will like to choose a traditional non-aspheric IOL with positive spherical aberration. If a patient has undergone a myopic, patient has usually have a more positive spherical aberration, so you'll use a lens with the wavefront negative spherical aberration. In irregular cornea, you like to use a aspheric neutral lenses. And if there is no previous refractive surgery, again good centration and uncompromised capsular bag is there, you can use a aspheric IOL with negative asphericity. And if there is any subluxation or the pseudo exfoliation, you may use a aspheric IOL with this thing, because this pentacam gives a asphericity value of cornea at 6 millimeter. Based on that, you can choose. And this is one case where one eye has a non-aspheric, other has a aspheric. You can see the Strehel ratio in the two. It is way close to 1 in the left eye, and in right eye it is almost 1/10 of the left eye, and the point spread function is very good in the left eye, so the quality of vision is very good. This is again on a pentacam, not on a pentacam, the earlier version of Nidec, this thing which shows very good point spread function. So based on this, we can have a lot of application of pentacam. I have not gone to detail of other. It has a lot of other uses in glaucoma, ICL, as well as intracorneal intakes. So it is a very versatile tool and can help us in various situations in analyzing progression of keratoconus, calculation of IL power, and all. Thank you so much.
Well, thank you very much, Professor Jain, for such a exhaustive talk. Any questions for Professor Jain, please? We can take one or two right now. It gives me great pleasure to invite Dr. Samar Basak for his talk on tear film diagnostics, LipiView and LipiFlow. Dr. Basak, please.
Good afternoon, friends. So my talk is on tear film diagnostic, LipiView and LipiFlow specifically. Thank you, Amit, for this wonderful course. But though less, audience is there, but I'll tell you that if you have any question in your mind, please ask us. We'll try to clarify at the end of this session. And I'll be talking mostly on LipiView and LipiFlow and to some extent on meibomian gland dysfunction. So this is a history of a girl, 8 years old. She had a history of using digital devices for more than 10 hours. And she came actually for recurrent red eyes itching and recurrent marginal keratitis for 1 year. When I asked about the screen time, her parents were very reluctant to admit that during the COVID time, she was actually spending almost 16 hours a day online classes for a leisure time on iPad, iPhone, etc. And she is continuing that habit till now. So we treated her medically. Then we ordered LipiView. And this is the picture of her meibomian gland. You see, it is the meibomian gland of a 80 years or 90 years old person. But she is having severe dropout areas, and you see the meibomian glands are scanty, all are blocked. Her LLT means lipid layer thickness is only 29, though reference is more than 60. I am talking in terms of nanometer. And she is a partial blinker, 100% partial blinker. So this is a horrible picture for me at the age of 8 years. So, meibomian gland dysfunction, lot of studies are there due to, and the prevalence is 38 to 68%. And if you see the Indian data, there are only few data are available, one from our place, one from RP center, and it is about 37 to 40%. So mammalian gland dysfunction are very important for many reasons. For like one is we are seeing this, we are living in digital era on screen, and other side we have a old population group. They are having mammalian gland dysfunction. Even for cataract surgery, there are several studies. 50% are of them with mammalian gland dysfunction, and among these 50% are asymptomatic. So there is a direct relation with cataract surgery, mammalian gland dysfunction, and dry eye. It is a vicious cycle. So there are other influences. There are plenty of papers, plenty, at least maybe more than 300, 400 papers on this. Influence of cataract surgery on mammalian gland dysfunction, assessment of tear film lipid layer thickness after cataract surgery, why the patients will come back and they will say that eye is itching and reflex watering are more, gritty sensation, all are there. All the patients used to complain after cataract surgery. Then there are certain meta-analysis of this, and more frequently it is observed those who is having pre-existing mammalian gland dysfunction. And this is a best of study I recently published in 21, that despite more knowledge and more accessible to treatment, MGD is highly prevalent among ophthalmic health workers with 61.4% prevalence. I'll show some figures. And so targeted therapy based on dynamic mammalian gland imaging is effective in improving both objective and subjective. So imaging part I am talking about, imaging is very important for laser refractive surgery also, and before and after the surgery. It is also important for other diseases, and ASCRS, they have given guideline how you look for a mammalian gland dysfunction. There is LLPP, look, lift, pull, and push. Push means to express the mammalian gland secretion. So when you are examining a patient under slit lamp for cataract evaluation, especially in the era of premium IOL, you must look for these signs before jump into the cataract surgery. Otherwise, you will be in trouble. The patient will be in trouble. So main thing is treat this patient before even doing a biometry, because biometry gives you erroneous value, maybe in the range of astigmatism, maybe in the range of absolute power. So LipiView, LipiScan is their previous version, and LipiFlow is the treatment part. I do not have any financial interest on this. So LipiView is basically interferometry with lipid layer thickness, as a blink dynamics they used to say. It is infrared mammography with transillumination device. And you know, all the oil, water, they create interference, and the whole system is based on that. Normal LLT is more than 60 nanometer, as I said earlier. And normal blink dynamics, if you see that blink dynamics is different. So there is high and low. So you see these interference fringes, and you can actually guess that something is wrong. Video captured this in high and low LLT. So with each blink, this moves, this fringes changes, and it changes with the level of mammalian gland dysfunction. So as I said, that there is 90% specificity of mammalian gland, and also the blink, conscious blinking, we do not do conscious blinking, so unconscious blinking, and many people are partial blinker, and it is proved that blink is the only thing which can save our meibomian gland. So there are direct, dynamic, and adaptive transformation and dual made to have a better, especially for lower lid. So this is the normal. You see that this is taken from their images, the company's images. So there is no dropout area, mild dropout, moderate dropout, and severe dropout. You see the gland also dilated in many tortuous, dilated, then fragmented glands. All are important. Then summary, it gives this summary report like the total when the, this is actually, you see that Dr. Bashak, it is not mine, my junior, his meibomian gland when he was like 29 years age. And you see that LLT is borderline. He plays a lot of with computer and game, and his meibomian glands are not healthy. So this kind of picture we have seen in many of our ophthalmic colleagues, and that is not good for long term. So we have several patients. I'll see a series of photograph, lower lid gross dropout, upper lid, in the left eye you see there is glob, average LLT less than 60. Then here both upper and lower lid you see that gross dropout, but there is a high LLT. This is false blinks. If the patient blinks before that forcible blinks, this causes high lipid layer thickness. Then both lid, you see that few dropout areas, but again low LLT, again very low, you see 20s and 25 and 30. So again false negative. All these questions are there. And this patient, when she came she asked for multifocal lens to me. I said it is a routine practice in our hospital. We ask for, and you see that extensive dropout area with false high LLT. And this patient is not at all suitable for multifocal lenses because this meibomian gland, if you see the lower lid, in the left eye, meibomian gland virtually not there, maybe 10% is remaining. So this patient will curse you. In pediatric MGD, it is increasing. So I have shown one picture because this is the cause. Smartphone is the cause. All the kids are playing with smartphone and iPads, and because they are not going out, even after the pandemic, now the fields are open, they are not going out, and they do not have the power of blink. They have forget how to blink, and their parents are, this is basically cycle of inflammation as going, and impact of partial blink or reduced blink on the meibomian gland is the inactivity of the glands which can insult the meibomian stasis. I call it in simple word that it is basically disease atrophy of meibomian gland. So you see that this is 11 years old child, lower lid you see, you will really not like this picture that 11 years old kid, what will be picture at the age of 60 years. So this is another 14 years female, you see that the picture is horrible. Again you see that this is 10 years male child, partial blinker, you see the blink rate it is, and the LLT is 25-30. Both leads at very gross dropout areas and also the shortening of the meibomian glands. So there are treatment available, the procedure based treatment, there are many, and there is a recent ongoing study on it, is called tear care also. So gland probing, initially gland expression, gland probing, leafy flow, MEVI flow, lot of cyst and ILAX, IPL, and then again tear care is coming. So all have positive, negative, but I will be talking on modal leafy flow, meibomian thermal pulsation. It is between like 41-43 Celsius. Both four leads are together, and it is actually 12-minute treatment cycle. and after 12 minutes that it is total procedures is around 20 minutes, so everything. How does it work? Thermal pulsation, heat from inner aspect and from outer aspect, and massaging of the leads, and the activator is like this. It is expensive, but it is effective. There is protection devices, the corneal shield and lead warmer. This is silicon inflation massager, and it works like this. So you see there is a animation given by the company people. They see that it expresses the mammalian gland secretion and also activated. So there are reports of visible mammalian gland structure increases after vector. This is called vector thermal pulsation treatment or LipiFlow. And people, we want to see this kind of picture in future, but probably not. We are getting maybe isolated, and there are numerous studies are going on, IPL versus LipiFlow or LipiFlow alone, then single treatment, multiple treatment, etc. are going across the world. And you see again from treatment point of view, there are several articles, and I am telling you next decade will be the decade of MGD. Cataract business has gone, and a lot of things will be coming for this patient, and they have treated, and they have seen the astigmatism pattern has been changes, so they have changes their toric lenses, power, value, whatever. Their prospective randomized studies are there before and after surgeries. Then you have different kind of comparison of that obstructive versus hyposecretory mammalian gland dysfunction, and compared systemic meta-analysis. So a lot of people are working on it. So indications: mixed or evaporative dry eye, routine preoperative investigation, postoperative patient. I'll take 1 minute more. Postoperative patient, both cataract, laser refractive, IT professional including teachers, students now, contact lens intolerant patient, allergic eye diseases, especially in VKC. We are doing one study in patient with continued AGMs, especially with PG analog for 2-3 years. Then you have to go for it, because PG analog destroys the mammalian gland. On the other hand, we know that beta blocker destroys the mucin goblet cells. So that to educate and explain the prognosis to the dry eye patient, that is, it is a very good teaching tool to the patient. Patient will understand. And whom do you treat? Understand the goal of therapy, willing to modify their lifestyle. It is not the only thing you have to change your lifestyle also. Affordability issue, and not that expensive. May need repeat treatment after 2 or 3 years. I have done twice in last 2 years. Additional therapy to MGD also to be continued, other than like erythromycin, doxycycline, hot compress, little bit steroid touch, ointment, massage, all these things. And it is works for PMIOL candidate, refractive surgery, older patient, pediatric MGD population is rising, IT workers, digital device. Take home message is: good surface is prerequisite for any predictable outcome in cataract and refractive surgery. Dry eye, MGD are basically going hand by hand. In any cases of dry eye, ultimately it will be going to mixed type of dry eye. Pre-procedure detection and treatment give optimal outcome, good for patient prognosis and education material. Vector thermal pulsation before the patient can modify your total planning and always improves the total outcome. Thank you very much for your patience hearing.
Thank you, sir, for such a nice talk. Any questions for Dr. Basak, please? Yeah, please.
Sujata.
Can you hear me?
Yes, yes.
So, does it match with symptoms and finding always? Does the symptoms and the finding match, correlate, or patients are not symptomatic?
No, it doesn't correlate. So the signs, if you invert the lid, it correlates. But symptom never correlates. Symptom, they are, especially in kids, They do not say anything. But when their mother or parents complain that he or she is rubbing his or her eyes more often than previous, or complaining of redness, occasional, and comes for consultation, you see nothing is there, you may find mild blepharitis. But if you invert the lid or lower lid pull, you see that yes, something is going wrong there. If the child is 8 years and above, you can do very good lippy view, even therapy, because the size itself, that activator smaller size, not available in India, but some palpebral fissure are larger, longer in length. And this pediatric, I am telling you, this population is increasing. So whosoever come for a Calazian in pediatric age group, for a marginal keratitis, there is no need from high-fi family, not from poor, unhygienic people they are from good families. And you ask this question, and then you subject them for lippy view or any other device of mammography that way. You will surprised to see my assumption we are going for. Right now I have 53 kids treatment has been done. So in various grades it is there. So they are more vulnerable nowadays.
What about the finding? What, because you get so many numbers, meibomian gland loss correlates with the lipid layer thickness, or it just there's no correlation?
Now vision, there is no correlation, but
vision,
dropout, fragmentation, yes, there is correlation with LLT, blocked gland. But sometime before this test, patient sits, no, they squeeze too much. If you squeeze right now, you will see there is an extra layer of lipid layer in front of your aqueous layer. You feel good for few seconds, and that time if the photographs capture, it will show higher LLT. So that is sometimes false, sometimes high. But if you give tissue paper, wait, relax, then majority of the cases it correlates.
How is the repeatability? Inter-test repeatability, is it good? If you test repeatability, for example.
Yes, it is reliable, very much reliable, because it is the gland deficit. Only the LLT part might be changing. That is a dynamic, but anatomically it remains same.
Yeah, anatomically it will
but LLT part is because of patients, like we see in other part, like fluorescent stain. If you take, sometimes it gives good result, but patient blinks more, different results, similar kind of thing.
Sir, have you seen dropout areas reversing after lipid flow treatment?
OCT.
The dropout areas that we see, do you think it reverses, or once the changes?
No, only one paper is available. So that is, I do not know, one paper, but theoretically it should not be reversible. Yes. How could a gland, tubular racemose gland, half of or two-thirds gone, how it will regenerate?
Correct.
By only vector pulse. Maybe one or two cases it happened. Right. Maybe blocked gland was there. Initially silhouette kind of picture was there. Now you block has relief, your gland is intact. That kind effect might be there.
Maybe. Abba, you have a question? Yes.
Sir, I'd like to know how early can we do a cataract or a refractive surgery post a lipid flow treatment?
So any post-op or a refractive or cataract, so in our rule of thumb that you wait for 3 months.
3 months.
3 months. You give, but if it is a significant findings like I have shown, but those are lost gland, it will never come back. But any dry eye patient, either evaporative or aqueous deficiency dry eye, the rule of thumb is for the next parameter checked, you have to give 3 months time. Whatever ways you treat the patient medically or this kind of devices, and you wait for 3 months, then look for the ocular surface, and then you take the test. Even they have beautiful paper on the astigmatism changes in 20% of the cases that initially you thought it is 2 diopter astigmatism, later you see no astigmatism. Sometimes it happens because it changes that we know that TR film is the fast refractive surface of your eye. So that is very important.
So my next question is also to you. So it's regarding IPL. Would an IPL bring any change in the aqueous secretion from the lacrimal gland?
No, I cannot get the URL.
So my question is whether IPL treatment would bring about any change in the aqueous secretion from the lacrimal gland?
Lacrimal gland?
Yes, sir.
No, I don't think. Amit?
I don't know if we are not using the IPL.
IPL, we have tried. IPL, there are a lot of both side plus point of there. IPL has got several companies, but LipiView is the only company is available. But other treatment, thermal based, LipiFlow and versus IPL, lot of papers are available. But again, temperature control, complexion of your skin, melanin content of your face, all differs. Here only mechanical things are happening at the same time. Thermal pulse at the level of 40-41 degrees Celsius. That is, we call it eye spa.
Right.
And it actually works for 2 years. I am telling you, I first done in 20, second time 22. It doesn't, no, nothing happens, so you enjoy.
Right. Thank you, sir.
Can I have one quick question? So do you think, is there a gender difference in the pediatric MGD patients?
Gender difference, all are pre-pubertal. All these kids I have shown 14 or below. No, there is no gender difference. I have not tested the group 14 to say 20 years. Probably that is a good suggestion. If I get a chance to get this group with some symptom, I'll try to catch them because their hormonal things will come. But these by and large 10, 11, 8 to 12 are the most kids.
Thank you.
But what Dr. Basak has said is like the ocular spa. We go to the spa to keep our bodies healthy. And if it was more affordable, sir, would you recommend that just as a part of those massage chairs which are lying in the lobby, and we just walk in and we make our glands healthy. So prevention is better than cure, and we don't wait for MGD to actually happen. And what are your thoughts on that, sir?
MGD is inevitable. What I realize that I do lot of tests, I do treat lot of patients. It is not expensive. You know that we work in a lower scale, but in our scenario, the investigative cost is only 900 to the patient. LipiView. LipiFlow is 15,000 only. In other places, it is 30,000 to 40,000, I know, and first one is 3,000. But there is no reason because it is done by only technician. I am not involved.
Correct.
So technician is doing.
Right. Right.
So break even easily ho jata hai. So there is no involvement of myself.
And it reduces the need for medication as well.
Yes, that is very important.
Drops are exorbitant.
And
if we
also, it will teach you, when you give the photograph, now this is your mammalian gland, and I always give a reference normal gland. See and comment yourself. Please avoid your unnecessary digital device practice. So,
correct.
Parents' education for the kids are very important for this.
Right. Well, thank you, sir. I'll move on to the last talk, which is the eye trace or the ray tracing aberrometry for corneal and lens-based refractive surgery. So, essentially, this is what an eye trace looks like, and it has two major components. It has an aberrometer, and it has a topographer, and also it has an autorefractor and optometer. So this is what makes it so reliable and so good, because it gives autorefraction, it gives placido-based corneal topography, it gives ray tracing aberrometry, it gives the pupillometry, it gives the keratometry in these patients. So the basic principle behind which the ray tracing works is that there are 64 shots fired in 4 rounds, which leads to 256 shots. And these sequential spots are they combined to form the retinal spot diagram and give us the point spread function. So since the patient is looking at a distant target with relaxed accommodation, the measurements are a lot more physiological than with other machines. Now, this is the problem with some of the more common aberrometers, which are using the Hartmann-Chack principle, or they are using the Schoening principle, or maybe the skioscopy. What happens is, like, we have lenslets and they fire a fixed signal into the eye. The signal comes out and we analyze that. Or what happens is, fixed spots are fired into the eye. They are analyzed once they exit the eye. Or in skioscopy, there's a broad beam kind of a pattern. But what happens, it leads to errors. There is something known as the crossover effect, or there is a duplication of points which are red, or some points are not red. So there are so many things by which uh, the ray tracing analysis is superior. This is more important not in normal eyes, but in eyes which have been operated, post RK eyes, post penetrating keratoplasties eyes, or patients of keratoconus, or some other things which are making the cornea irregular. This is where the eye trace really becomes so much more reliable than standard barometers. Now, if you look at the concept of this ray tracing, you will see that each of these rays is falling on a different spot on the retina. When it exits, it is being analyzed, and that is what makes it so special. It's one comment is that if you must take precautions when we are doing the ray tracing. The patient has to look through a target, through a distant target, and relax the accommodation. That's how you will get most reliable readings. Now, what can we use the eye trace for? We can use it for preoperative planning and cataract and refractive surgery. And we can also use it to decide whether does the patient need cataract surgery or not. And we can use it to diagnose any lenticular pathology in patients, and also to one of the ways to assess the visual outcomes both of cataract surgery, refractive surgery, or any other procedure. We can use it for toric IOL alignment, and we can also, in case of post-refractive surgery patients, use this machine to decide whether the patient needs an enhancement or not, or also whether the patient is a good candidate for multifocal IOLs or not. So, one of the programs that we used in cataract surgery is the topography and the aberrometry combined. Now, the most important thing here is that there is a data verification that we can do. We know that garbage in is garbage out, and that is where here it gives you at a glance how many spots have actually been registered, studied, and by the machine before the report has been given. So this is a quick assessment of the patient's visual system actually can be done just by looking at the verification display which is there in this machine. It also gives us the tracy refraction and the aberrometric summary of this patient. And tracy refraction is color coded. If it is green in color, it means that it is something that we can correct easily. However, if it is red in color, it means that either it requires a surgical treatment or a customized approach to rectify that particular problem. Now, we have the wavefront display map. And so what it does is that if many times, if you just look at this map, just look at this is a girl who had come for refractive surgery, and we can see by internal, we mean this aberrations are actually limited to the lens or the lenticular system of the eye. So a green equal color is considered to be normal. If we see anything else that is variegated in appearance, has multicolors, rainbow colors, it's something is very wrong with the eye. So there's something known as the Chang analysis, and just at a glance, it quantifies the ocular aberrations in the eye of the patient. If you look at cataract in these patients, now this patient actually had been subjected to a CT scan. He said he had complaints of diplopia. He had a reasonably good vision, 6/9 vision, which was correcting to in both eyes. But when we take a close look at the map of the patient, it shows an opacity grade which is more than 2.5, and it also shows a DLI value. So these are the kind of gradings which are given on the eye trace. The DLI is also the dysfunctional lens index. Now, this is again, we really don't know exactly how the Tracy Technologies has developed this nomogram to calculate the DLI, but it relies on the natural aging changes of the lens, as well as the diminished optical performance of the lens, and possibly it correlates them with the higher order aberrations, visual acuity, and contrast sensitivity of the lens. So it uses certain parameters to give us one quantitative value that we can use and apply in a patient of cataract surgery. So a DLI less than 5 may be considered that the patient may be benefiting significantly if the patient undergoes a cataract surgery. This is not to be applied blindly on patients. There are errors like, for example, high myopia or other kind of lenticular aberrations. It will give a false kind of a reading, and we have to be very cautious while interpreting it. So if then we look at the corneal and the internal lenticular profile and the vision simulator of the patient. Now, if we look at the vision simulator, this is a very useful tool for us to educate the patient as to what they are having. So it shows us on an E, and it shows the kind of, for example, if we look at this patient, this is the corneal vision simulator. It shows the cornea is almost normal in this patient. It is the internal or the lens system which is more defective in this patient. So if we take a close look at the opacity grade in this patient, and sure enough, when you look at the Chang analysis, it shows that there is the cornea shows an astigmatism that can be easily corrected by refractive surgery and other toric IOLs or something. But if you look at the lenticular system, this patient had come to us for refractive surgery, and this patient had had a lens coloboma, which was the cause of her visual problems. Again, just to clarify this, look at the color patterns on a wavefront map. You will see a smooth green color. This is the cornea. It shows the cornea is normal. And if you look at the internal aberrations wavefront map, and you will see that all these kind of rainbow colors are there, and this indicates some abnormality is there in the patient. Now we have patients of posterior capsular opacification coming to us, and we don't know whether we should actually do the YAG. Is the patient going to benefit from a YAG capsulotomy or not, especially in earlier stages? So PCO like this, and in this patient, again, it shows that there is the DLI goes down, and it shows that maybe, and also we look at the opacity grade, and it shows that this patient is a good candidate for doing a YAG capsulotomy. In cases of scaled fixated IOLs, if the IOL is misaligned, it will show us the high grade of coma, that is the cause of the visual complaints. It also, in these kind of maps, it has this little spectacle mark. So it shows that what a patient, how he will see with spectacle correction. So in some of the situations, if we click on it and the vision improves, or the vision simulator shows an improvement, it means that just giving spectacles would be a good idea, and the patient might see better. Now, I will not go into this, but for toric IOLs, there's a specific program designed for toric IOL, not only to align it pre-surgery, but also to check its alignment post-surgery, and also that to decide whether there is a significant amount of malalignment, and we need to undertake the surgery to correct the toric IOL alignment or not. Now, to decide whether if there's some residual refractive error, sometimes we get patients who have very little residual refractive error, but they are highly symptomatic. We can't figure out what's wrong with this eye and how to go about it. So if you look, there's something known as the MTF, or the modulation transfer function. Essentially, it is a numerical value, or it's a chart along with the numerical value. It tells us whether what is the contrast of or the visual quality of this optical system of the patient's eye. For example, in this patient, you will see in one eye, you will see that this is the map, the corneal map, and you can see here it is above this red box. Now, this red box is corresponding to 40% contrast and 10 cycles of spatial frequency. So any line which is above that is considered to be good optics, and if the line is below that, it's considered to be bad optics, right? And such a patient underwent enhancement. We lifted the flap up, and we just took care of the refractive error of the patient. And this is the image which is post enhancement. Patient was very happy with that, and we can see the changes in the slope of the MTF of this patient. So finally, cataract surgery, the bread and butter of so many ophthalmologists. There are so many ways in which an eye trace can help us, including alpha D, the MTF, the IOL selection analysis. So if we look, essentially, what is angle kappa? Angle kappa is the angle of the visual axis to the pupillary center, and angle alpha is the visual axis to the limbus. So angle alpha basically tells us how well the intraocular lens is going to be centered inside the bag once the cataract is out. And of course, that if it is high, it means that in premium IOLs or multifocal IOLs, or if there's a misalignment, the optics will not be good, and the patient will not be happy or a good candidate. So if you look at a simple algorithm for selecting the IOLs, we perform the eye trace, we assess the optical alignment with angle alpha and kappa. If the angle kappa is more than 0.5, we should go in for preferably a monofocal IOL. Or if the angle kappa is less than 0.5, then we can look at the Chang analysis if the corneal aberrations are less than 0.14 or more than 0.14. If there are significant corneal aberrations, we should again prefer a monofocal IOL and not go in for a multifocal or a premium IOL. In case the corneal aberrations are low, then we look at the IOL skin, see if the patient needs a toric IOL or not, and we can go in for premium IOLs in these patients. Just in order to make all this simple, they have given something known as an IOL selection analysis, and it says here, is the tracy refraction normal? Yes or no? Is the corneal higher order aberrations present? No. So this patient, and are the internal HO is present? Yes. This is because of the cataract. So it automatically gives us that we can go in for a premium IOL or not in these patients. So just to make the life simple for cataract surgery, cataract patients. So to conclude, a 2020 unhappy patient is unacceptable in the 21st century, and in this new era of cataract and refractive surgery, I think the eye trace is an invaluable tool, and this is not only for planning of the surgery, but also to communicate with the patient and to understand the outcomes of surgery, and also to assess our own outcomes, how we are doing in a better way. Thank you so much.
Chalo, time is right time.
Oh, sir, we had the keynote address. We have time otherwise.
Time?
We had the keynote address we have adjusted.
No, it is now 3, no? 3 tak.
Yeah, she had इनका additional time.
इनका तो आगे हो गया ना?
नहीं, सर मैं बात का पहले कर दिया.
अच्छा, बाद में. Okay.
Any questions? Otherwise, we will wind up. It's already 3 o'clock, and thank you very much for being here. I would like to thank all the speakers, Professor Arun Jain, Dr. Ko, and Dr. Samar Basak for being here with me. I would like to invite all the co-instructors to come on stage for the photograph.